Codeine, or locally known as is an opiate and prodrug of morphine mainly used to treat pain. In the liver, the cytochrome enzyme converts codeine into its primary active metabolite, morphine. The active opioid binds to the myo-opioid receptors in the central nervous system. This binding leads to the inhibition of ascending pain pathways, causing CNS depression, and triggers the release of dopamine, which produces the sought-after feelings of euphoria, relaxation, and sedation. It's a public health concern in Zambia because it's being abused recreationally by the youth primarily due to its relaxing, high, a rewarding stimulus which addicted individuals are compelled to replicate. Usually, it comes as a combined product with paracetamol, nonsteroidal anti-inflammatory drugs, caffeine, antihistamines, promethazine, or other compounds. The classic clinical presentation of severe overdose is known as the opioid triad. It consists of pinpoint pupils, altered mental status, and respiratory depression. The pathophysiology of codeine toxicity is fundamentally driven by the excessive agonism of opioid receptors in the central nervous system, primarily by its active and potent metabolite, morphine, resulting from the direct suppression of the medullary respiratory center. This shallow and slow breathing causes life-threatening hypoxia and hypercapnia, which can rapidly lead to respiratory arrest and death if left untreated. Additional effects include hypertension, bradycardia, and reduced gastrointestinal motility, with severity significantly in individuals who have ingested codeine in combination with other CNS depressants. The clinical picture of an opioid overdose begins with severe CNS depression. This manifests as a diminished mental status that ranges from extreme lethargy and confusion to stupor or even coma. The body will be flaccid, with muscles relaxed and deep tendon reflexes often depressed. If the patient is awake, they may display signs of impaired motor function, such as dizziness, lack of balance, or slurred speech. A critical sign is the effect on the head and eyes, where the pupils are typically constricted or pinpoint like mentioned earlier, which is due to parasympathetic stimulation. However, this classic sign may be absent if the patient has co-ingested other drugs like stimulants or anticholinergics or due to severe oxygen deprivation. The most life-threatening feature is the impact on the respiratory system, characterized by slow, shallow, and/or irregular breathing. Airway obstruction is common, signaled by snoring or gurgling sounds called a death rattle, which is caused by an unresponsive tongue or secretions. Furthermore, auscultation of the lungs may reveal pulmonary edema, heard as rowls or crackles, which can sometimes lead to the production of frothy pink sputum in severe cases. The patient's skin and appearance provide visual evidence of oxygen deprivation. The lips, nail beds, and skin will appear bluish or purplish due to a lack of oxygen in the blood. In darker-skinned individuals, this may present as a grayish or ashen color. The skin is typically cold and clammy. Medical providers will look for track marks or fresh needle marks if the drug was injected intravenously. In rare instances, excessive doses can lead to complications such as seizure, serotonin syndrome, anaphylaxis, anaphylactoid reaction, or even androgen deficiency. The primary investigations for suspected codeine toxicity include a urine drug screen to confirm the presence of opiates, acetaminophen, and salicylate levels to rule out potentially fatal co-ingestions from combination products. Supportive tests are then ordered to assess the severity of respiratory depression and associated organ damage. The first one is an ABG, which is critical to check for respiratory acidosis and hypoxia. Secondly, urea and creatinine, for monitor renal function and electrolyte balance. Liver function tests are essential to detect liver damage, particularly from acetaminophen co-ingestion. Creatine kinase screens for rhabdomyolysis due to prolonged immobility. Finally, an ECG is performed to rule out cardiac conduction abnormalities that might be caused by other co-ingestants. The management of an opioid overdose begins before the patient reaches the hospital with basic life support, specifically initiating cardiopulmonary resuscitation with a focus on rescue breathing if the person is unresponsive and not breathing normally, and administering naloxone if available at home, before placing an unconscious but breathing patient in the recovery position. Hospital management follows the ABC approach, where securing the airway and providing adequate oxygenation and ventilation are crucial steps. The antidote naloxone is then administered intravenously and titrated starting with 0.4 to 2 mg and repeating every 2 to 3 minutes, not exceeding 10 mg to reverse respiratory depression while carefully avoiding severe acute withdrawal. Due to the risk of resedation from naloxone's short half-life, patients require continuous monitoring for 4 to 6 hours and may need a continuous 4-naloxone infusion. Finally, management includes treating any co-ingested substances like administering acetylcysteine for paracetamol toxicity, and ensuring discharge planning involves prescribing a take-home naloxone kit and providing referrals for opioid use disorder treatment.